Good afternoon, everybody. Thank you so much for joining us for today's session of the CRISM Addiction Rounds series. My name is Catherine Dong, and I'll be your host for today. Please note that this webinar is being recorded and will be posted on the CRISM prairies.ca website. I'd like to open our session today with a territorial acknowledgement. The Canadian Research Initiative in Substance Matters has members from across all of Turtle Island, the land now known as Canada. We acknowledge that Indigenous peoples are the traditional guardians of this land and respect the sovereignty, lands, histories, languages, knowledge systems, and cultures of First Nations, Métis, and Inuit nations. Ongoing criminalization, discrimination, and institutionalization of people who use drugs disproportionately harm Indigenous peoples. As such, we commit to ensuring this series is anti-racist, anti-colonial, and serves as one way to dismantle colonial structures that contribute to ongoing oppression. If you have questions during the session, please use the Q&A feature to send questions to the hosts and panelists at any point during the session, and we'll reserve the last 15 minutes for questions from the audience. We really value your feedback. It really helps us improve these round series, so please complete the series evaluation, which you'll receive by email after the session. Completion of this evaluation will also allow you to request a certificate of attendance for your records. And I would now like to introduce our speaker. Donald O'Doherty is a clinical nurse specialist for the Edmonton Zone Emergency Departments, a flight nurse and research coordinator with STARS, and an adjunct assistant professor with the University of Alberta's Department of Emergency Medicine. He has a background in intensive care, emergency department, and transport nursing, and has recreational and some professional research interests in these clinical areas. Outside of work, he stays busy chasing his twins around. Thank you so much for joining us, and I'll turn it over to you.
Great. Well, thank you very much, Dr. Dong. I'm here presenting these slides as part of our combined work with Dr. Scott MacLean. He sends his regrets. He had a last-minute flight cancellation from the Dominican Republic. I did suggest him rebooking for about 3 weeks' time after this cold spell, but I think he's currently on a flight right now. And so I'm going to be presenting on our work on Frostbite within the Edmonton Zone. Just need to move my slides forward somehow. There we go. And so disclosures. And so this is just a disclosure slide. We do have a formal study ongoing around the use of Frostbite, the assessment of Frostbite in our zone and in the province. And this is standard disclosure slide from Dr. MacLean and myself. We did receive some funding from RNet, who graciously funded our research in 2024. And I am otherwise employed by AHS and STARS, and I have no other financial agreement affiliations. And the study also involved a host of collaborators with our work, and we also work closely with the Canadian Frostbite Care Network as well as community partners. Thank you for the previous line acknowledgement, and this presentation is coming from Treaty 6 territory. And the objectives of this talk is understanding the diagnosis, management, and follow-up of frostbite, identifying factors that may contribute to the incidence of severe frostbite, and specifically we'll be looking at homelessness and substance use within those as some of the key drivers. And then we'll also review and discuss strategies to improve care and reduce disease severity in patients with severe frostbite. And so just taking a step back, and so really there was a lot of excitement started off in 2019 when we saw an increase in cold exposure within our Edmonton EMS crews. And then the next couple of years later, the alarm bells were ringing from an emergency physician point of view, where there were significantly more amputations specifically in our homeless population and our communities. The following year, we actually hit a 10-year high within Edmonton from the previous winter. Just going to turn off that. And then the year afterwards as well, we had hit a new high in amputations, the highest in more than a decade. And again, we broke more records from an amputation point of view. And so, and there was there's also separation in care between Edmonton and Calgary. That is really quite an illuminating graphic. And so traditionally frostbite, and so looking at amputations for severe frostbite is a pretty gross measure, but it's pretty specific to, counting digits and toes. Understanding that within the patient population, this only captures hospital created amputations. So if a toe falls off in someone's sock, it wouldn't be correct. It wouldn't be collected in this data. And we understand that there is a level of self-amputation and amputation outside of the health service that kind of occurs. But traditionally, there was a pretty standard baseline where Edmonton had about 2.5 times the ratio of Calgary over the years from 2011 onwards. And we had a significant increase in the winters of 2021, 22, and then a profound separation in amputation rates between Edmonton and Calgary from 22, 23, and 23, 24. So quite a striking report. And just to try to get an understanding of what's going on there, when we look at temperatures between Edmonton and Calgary, there's not a massive difference over time when we look at our averages, highs and lows. Although I would draw your attention to the daytime highs in Edmonton of -5 and -7 January and December compared to the -1, -2. And that -5, -7 number is kind of important as well, I believe. When we look at our homelessness in Edmonton and Calgary, from Homeward Trust data, there's relatively similar ratios of unsheltered population between Edmonton and Calgary, potentially with Edmonton having a slightly higher levels. Of note, though, when we look at the unsheltered population, this is within Edmonton here. When we look at the unsheltered population, but from 2020 to 2025, there's been an almost a 3 times increase in unsheltered population that potentially is a factor. And then when we consider getting good data around overdoses, in particular overdoses that are exposed to cold weather, is challenging. This is kind of gross numbers looking at Edmonton and Calgary, but there's been a 3-fold increase in EMS response to overdoses over the period of time. And I know, for example, last winter in February, EMS Metro were responding to 30 overdoses when they required a BVM, back valve mask ventilation, per day in February. And some of those cases would have occurred outside, exposed to cold weather. But when we look at the treatment difference from an acute care point of view between Edmonton and Calgary, within the Edmonton zone, previous to 2024-25 winter, severe injuries, the most severe frostbite injuries within 24 hours of presentation were provided with tenecteplase and heparin, and then burns, wound care, and then delayed amputation for ongoing injuries at that point. And then within Calgary, for all severe grades of frostbite from 2 to 4, within 3 days of injury, 3 days of rewarming, iloprost was offered for a 5-day therapy, as well as the tenecteplase heparin for grade 4, and then follow up with burns, wound care, and delayed amputation. And so the primary difference between the two zones were the use of iloprost. And so iloprost is a prostaglandin. Its off-label use for frostbite has been approved, and it's accessed via the Health Canada Special Access Program. So just taking a step back, when we talk about acute frostbite, we talk about grading of it. And so we use the Gauci grade for acute frostbite, and this is occur. And so when you talk about grade 1, 2, 3, and 4, this grading is a clinical grade where you're assessing for ongoing cyanosis or tissue hypoperfusion after rewarming. And so grade 1 is no ongoing cyanosis. Grade 2 has cyanosis just to the tips of the fingers and toes. Grade 3 cyanosis crosses the dip joint and up to the MIP joint. And then appreciate that crossing the dip joint and then all the way to the MIP is crossing 2 segments. So grade 3 actually crosses a lot of different severity, and then grade 4 is when there is cyanosis into the metacarpals or the metatarsals, and then the risk of amputation significantly increases with the grade. And it's kind of, that's how we describe it. There is other grading systems that use kind of advanced imaging, but those are less useful because the grading for acute frostbite is a clinical decision, and then the decision for therapy is based on this. So the Yukon protocol This was published in the Canadian Medical Association back from 2021. And so the Yukon Whitehorse Protocol has been in place for about 15 years now, provides rapid rewarming. And then based on grade of therapy, you'd either have iloprost, a 6-hour infusion daily for 5 days, or for grade 4, it would be iloprost and within 24 hours, alteplase. And based on that protocol, they assessed over 5 years. They treated 22 patients with grade 2 to 4 frostbite. They assessed the per digit effects and from grade 2 to 4, and then they amputated. The 29 digits were amputated all in grade 4 cases. Interesting enough, alcohol was associated with about almost a third of cases. And out of the 6 cases that were involved, 5 of those were the most severe. So intoxication definitely has a factor to play in severity of injury in the Yukon data. Outside of those 6 cases, a lot of the Yukon data, Dr. Alex Poole kind of drove this work forward from a surgeon in Whitehorse. And a lot of the Yukon data comes from European adventure racers who are running around in minus a million in unprepared shoes and kind of doing these Arctic adventure races. So they were otherwise healthy individuals. When we look at Calgary data, so Calgary introduced iloprost in 2019 onwards, and they looked at a before and after study with their use of impact of iloprost. They reported no amputations in grade 2, and then they reported a significant reduction in amputations in grade 3, 18% with iloprost and 44% without. And then in grade 4 cases, they had a 46% amputation rate with iloprost and 95% without, and so significant reductions in severity of injury. So the ongoing amputation, the higher amputation rate with iloprost in the grade 4 compared to the Whitehorse data suggests just a different patient population, potentially a later presentation or more comorbidities. And so we looked in Edmonton at our data, and we also looked at Edmonton and Calgary. So we conducted a study with Dr. Scott MacLean as PI, which from 2021 through to 2024. We looked at Connect Care data, so computerized data. We looked at included a lot of cases, excluded a bunch of older injuries and delayed injuries, and then we had 257 cases included in our study. Of note, and it was an interesting use of, we used figure 1. We described patients that turned up. We recognized that we had a significant proportion of patients, 144 patients left our emergers after being triaged and then 26% of those, so 38 patients, returned outside of the treatment window that had significant injury based on their primary presentation. And so that was a failure to treat that patient population there, which definitely from an acute care point of view, we own those patients. When we looked at our cases between Edmonton and Calgary over those period of times, we had 177 cases treated without iloprost and 80 cases treated with iloprost. And I think 2 cases in Edmonton were given iloprost and 78 in Calgary. So this pretty much represents at a high level an Edmonton and Calgary comparison. When we look at our homeless presentation and substance use, 54% of the cases were individuals experiencing homelessness as a precipitating cause, and almost 60%, 59% of cases had a note of active substance use disorder on their file. And so when we looked at the iloprost impact on overall amputation rate within that population, iloprost was noted to be associated with a decreased likelihood of any amputation, but there's no differences noted in grade 2 and grade 4. And the biggest impact was noted in that grade 3 group. So we had a 30% amputation with iloprost compared to 52%. And that was just assessing amputation as a yes-no kind of marker. Of interest, we also noted, when we looked at just the Calgary data, we also noted that there was a dose response to iloprost, where those that received a larger per kilo dose actually had a lower amputation rate and severity. When we looked at the grade 4 cases by segment, because you assessed if you have a grade 4 case, you're assessed as likely to have an amputation. So using a amputation yes/no metric is not doesn't capture the full picture in grade 4 cases. When we looked at the percentage salvage rate between ill-opposed and non-ill-opposed cases, we identified a statistical significant difference or association between ill-opposed therapy and improved salvage digits in both hands and feet, or fingers and toes. And so moving on to the precipitating frostbite cases, from the 2022-24 data, homelessness was responsible for, this was when we're looking at what was the noted precipitating factor on the clinical chart. So we went into the chart and we looked for the reason in the clinical note where the patient received frostbite. And homelessness was the highest precipitating factor, followed by substance intoxication, and then some walking outside, some alcohol intoxication was there. Of note, the sports-related cases were 2%, so very much a different population than kind of a white horse or a wilderness medicine kind of skiing, ice climbing type population. When we compare our Edmonton data from 23-24 winters to 24-25 winter, we have a significant change in our homelessness precipitating factors, moving from 43% to 62% of cases, as well as our substance use and E2OH. And so predominantly the drivers of acute frostbite within the Edmonton zone is insecure housing, substance use, E2OH, with a level of mental health component in there as well. And what we found looking at the 2022-24 data is patients with more severe injuries were more likely to experience homelessness. And so when we compare grade 2 on the left, which is pretty even between homelessness and housing insecurity, when we look at grade 3, it was pretty much a 100% more cases, and in grade 4 is that case as well. And we identified that unhoused patients were more likely to have delay in presentation for care. And the key piece with this is our treatment windows for acute therapy is less than 24 hours for alteplase, and then less than 72 hours for iloprost. And so what this demonstrated was that there was a significant delay presentation for those individuals experiencing homelessness. The greater than 72 hours included in the study were in some cases it's really hard to find clinically to establish the rewarming time, and so in some cases acute therapy was provided outside of that 72-hour window. It was kind of considered acute and treated accordingly. So that's where that piece comes in. And so taking a step back, frostbite, a little bit like a lot of trauma, is preventable, is treatable, and it is a life-changing injury. We're just talking about so far about digits, amputations, a gross amputation, fingers and toes being lost. We're not even getting into the weeds around morbidity, where you've got decreased sensation, chronic pain, or any of that kind of setting. And so there's a lot more work to be doing in that field. But just to improve the frostbite assessment and immediate management, when we're looking at it from an acute care emergency department point of view, prioritizing treatment and management. So what we did from a winters 24-25 in Edmonton, we looked to match Calgary and Red Deer's kind of lead within the province to implement an acute care pathway to support timely and acute frostbite care. We looked to screen all patients upon an ED arrival when it's cold. We assigned a high triage acuity score, understanding that this is a life-threatening, a limb-threatening presentation, and should be treated accordingly. And the easy analogy that I use with our staff members is, if somebody turns up with a baggie full of digits after a table saw misadventure, we kind of know that that patient needs to get timely plastic surgery intervention. When someone turns up with frozen digits, there needs to be a lot of nursing work to be done around rewarming and potentially treating that. But the outcome in terms of morbidity and digit salvage is potentially the same. What if there's so after assigning a high acuity score, if there's a frozen tissue that needs to be timely rewarmed, with consideration for analgesia, and then after rewarming, grading the injury, and then consideration of timely medical therapy. This is our pathway in the Edmonton zone, where we consider the grade based on the Calgary and the Whitehorse model, and as well as some supportive care, as well as a consultation. And we consult to admit to GIM and family medicine unless they need timely burns plastics intervention. And then we also consider alter place for some grade 3 cases based on burns input. And the reason why we added that in is grade 3 could be 1 digit that's just crossing the dip joint, or it could be 10 digits that approach the metacarpals, and so that would have a completely different risk profile for consideration of amputation, and obviously should be considered for, and that's where the alter place consideration comes in. It's a case by case consideration. And so when we rolled out this acute care pathway, we messaged out to our community providers that prior to the 24-25 in Edmonton, there was limited treatment options for frostbite in the Edmonton zone. And then considering the use of this novel treatment for iloprost, we were looking to decrease the risk of amputation, as well as also supporting treatments beyond the 24-hour period, understanding that a significant proportion of patients present after that period of time. And so we also met with, when we introduced this pathway, we met with our community support groups, our shelters, regarding treatment options, and to try to support folks presenting earlier with frostbite. And so they did a lot of work in the community to kind of support that as well. When we assess, we're still assessing the impact of our 24-25 protocol, but we did admit, we had 2 cases admitted for iloprost in the 23-24 winter, and we admitted 152 cases for iloprost therapy within Edmonton, and that was compared to 74 cases in Calgary over the same time period. And I believe one of the ALEC, I believe, had more cases admitted than all of Calgary combined. And that pretty much represents the highest case volume that we're aware of in the world of the use of iloprost, as well as the previously reported CBC amputation rate that again represents the highest case volume of frostbite that we're aware of in the world. We're looking at the data currently, and we're kind of diving into it. And then just of note, when we look at the 25-26 of this winter, we've already treated and admitted 173 people for iloprost therapy. We had a pretty big a bad start to the winter, and so our winter this year is already worse than last winter, and that's before we take into account the -27 temperatures that we have outside currently. So I would expect that to be this winter is going to be the worst on record for us again. So when we look at primary prevention and system factors for prevention, this is a preventable illness or injury in many cases. Edmonton City currently has an extreme cold weather response. When we assessed for cases, about 1 in 4 cases of severe frostbite occurred outside of the city of Edmonton's current extreme cold weather response period. And that's when the city puts on additional shelter beds and additional transport options to kind of support vulnerable population. But in those cases, we identified 23% of all cases occurred outside of the cold weather response, and 35% of cases in patients experiencing homelessness. But of note, we did note that 65% of cases occurred irrespective of cold weather or during a cold weather response. When we look at temperatures in our data, and this is Edmonton and Calgary data, severe frostbite cases graded 2 to 4 start happening at -5 in our population. And I think this winter we started reporting them around -3 at a very small number, but the inflection point was definitely -5, and then all the way through to our coldest temperatures. When we look at daily temperatures, and this is ambient daily temperatures and grade of injuries 2, 3, and 4, 40% of grade 4 cases occur warmer than -20, and they actually start occurring at -5. So some of our most severe cases occurred at that -5 to that -10 range, which was certainly a surprise to me. And that just reflects exposure over time. So if you're out all night with inappropriate clothing, you're going to have severe frostbite in that case. I circled the red line here just because it's the limitation of the data in Frostbite. And so when we had -35 to -40, we had a significant spike in grade 3 and grade 4, grade 2 and grade 3 cases, but we didn't have that same spike in grade 4. And what we believe that represents is a lack of capturing. We excluded hypothermic cardiac arrests, and so if you're exposed to those type of temperatures for too long, there's a very fine line between freezing your hands and feet versus versus your core and dropping into a cardiac arrest at that point. And so that's what we think is going on there. So when we look at what the threshold should be, I think Vancouver has a threshold of 0 degrees, which is quite extreme, I think. But in terms of what we believe, I think what we believe is cold weather response should be evidence-based. When does the frostbite cases occur? And that's when temperatures drop below 0. In our population, we identify those severe cases at -3 to 5. And then we should also be looking at cold weather response should focus on the outcomes. Are the services leading to a reduction in injury? So are the current services during a cold weather response adequate to meet the needs? And based on our ongoing increase in cases year over year, that would be a question mark. And then are there patterns in the injury that might point to alternative options in response? And what this requires is partnership with our community partners, the city, the province, and the health authorities are all needed here. And I guess that would include our multiple health authorities. There are some obstacles and challenges to care. And so a standard patient journey, and this is coming from the point when the patient actually presents to the emerge and we are able to admit them. We do have, like I believe lots of emerge departments in the country currently, we do have a significant press on our emerge departments. I think our high watermark is 120 patients in our waiting room, so it's really hard to kind of provide appropriate care to 20 life-threatening CTAS-2 presentations while also considering a CTAS-2 limb-threatening injury, and so that still is an ongoing press currently within our acute care systems. But just taking that aside, once we get you in the door, get you a bucket of warm water to warm you up, treat your pain when we're rewarming you, and then we can get you, and if you have ongoing severe injury, we'll get Illiprol started. Consideration for tenecteplase. That would require then a 5-day admission to hospital for Illiprost. Once you've been discharged from hospital, you still require daily wound care, and then a follow up with plastic surgery or burns clinic for within a month to consider surgical care if indicated, and then ongoing rehabilitation and follow up. And that's kind of the kind of current acute care journey. But with that journey, we have to consider that a high percentage of our patients are experiencing homelessness and substance use disorder. And so we have a percentage of patients that are lost to follow-up. There is a percentage of patients that AMA from our hospitals. It's around 5 to 7%. But substance use and alcohol use disorder does significantly increase the left without being left against medical advice. There's the need to attend to daily wound care, and this inability to access primary care or wound care, need to get to a plastic surgery clinic, lack of phone transport, all the barriers to accessing care. And I think the key piece on this is our community partners are vital, play a vital role in supporting this population in the community, and increasing their capacity is important. And I think in admission to hospital, if we're looking at not primary prevention, but at least secondary prevention, then primary prevention would be ensuring that people are appropriately housed and supported in their substance use journey. But if we're looking at secondary prevention, then I believe an admission to hospital would be an opportunity during that 5-day therapy window to provide wraparound supports for an individual. And so a possible patient journey to an acute care would be, after ED presentation, would be admission. We wrap around community social work consultation to assess housing assessments, substance use counseling and treatment via addictions management team, daily wound care, ongoing social supports, and then transition beds on discharge to support wound care and ongoing management, and then outreach clinics for reassessment and surgical care as needed. and then ongoing social and housing supports. And it takes the one example of a collaborative approach. And so there's pop-up wound care clinics, expansion of services for wound care at shelters. I believe some of these have already been implemented within our zone and within our city. Education of social services shelter staff to identify severe frostbite cases and refer to care. Um, and I think there's a complex reason, I believe, why patients don't present late to emerge after primary injury, and that probably needs to be dived into in a little bit more detail, as well as trying to decrease the barriers to access acute care assessment and treatment. Um, we have met with the city staff that work on the extreme weather response to provide evidence base of what our population is and what the strategies could be used to move forward, and that's some ongoing work with that. And then another example would be the use of community paramedics through MIH to assess and manage complex wounds in the community and follow up and outreach. This is an example of a checklist, not a checklist, a referral tool and a support tool for a non-healthcare provider to use to assess wounds and whether it needs to and what type of care it needs. And they've added a frostbite section. They went backwards and forwards with our community partners and some stakeholders on this piece. But this was the frostbite section where you're trying to assess the type of wound and whether it needs, whether it's a high risk wound that requires timely consideration for medical therapy. And that's an example of a tool that our community providers can implement and support. I'm going to wrap things up earlier at this point because I've kind of rushed through, and I'm very happy to take questions and
Oh, thank you so much for that excellent overview. It's really exciting to see this work presented and captured in this way. And I think it's directly relates to much of the work that people attending this webinar do. So thank you so much. I'm going to take a question that just came into the Q&A. So question reads, incredible data and ideas. Thank you for sharing. I'm wondering if you and your team are considering doing a cost comparison analysis of how much our city spent on frostbite management, so including iloprost admission, et cetera. It would be interesting number to have because perhaps we could use it to lobby our government for more funding to put towards preventive measures, such as housing, warm clothing, cold response, et cetera.
Yeah, that's an excellent question, Hope. The original study, we had a plan to do that as an original study. My background is acute care clinical nurse specialist in emerge, and so this is outside my wheelhouse, and this was well off the side of my desk. It was kind of butting to some degree into recreational research. I did approach at the time when we were setting this up some potential stakeholders to consider this and what they would need for additional data points. But they were at the time; those individuals weren't at the point of driving it forward themselves. I think there's ongoing interest in that question, and with the 24-25 data set locally, I think we could potentially look at that again because yeah, absolutely. I think the impact of 170 people being admitted for 5 days worth of therapy has a price tag associated with it. And so, yeah, and I think especially when both from supporting primary prevention as well as secondary, and I think there is provincial interest in that question as well. And so I think answer the question is yes. Hopefully we'll figure that out, but that won't be me doing the analysis. Tagged into the right people to ask the right questions for sure.
Yeah, great question. Thank you. Donald, I talk to patients that I see a lot about prevention. Are there some key messages around prevention that you think we should be talking to people about, and key advice that we should be giving people when we see them if we work in clinical settings?
It's a good question. I think it'd be interesting to know what their understanding is of the dangers of frostbite. And I think to assume that they don't have a good understanding of that this is a limb-threatening injury, um, I think I would start with questioning around in the same way as you'd approach harm reductions, any other harm reduction strategy. I think would be taking the same approach of this is be another consideration of how you would have those harm reduction conversations. I think this has this is a real in this whether it's frostbite or cardiac arrest from substance use or hypothermic cardiac arrest. I think it would be another this is an injury that has life-changing impacts. I think starting that conversation with an open mind and seeing where their knowledge is first. They might be choosing from some individuals I'm aware of that they choose the risk of frostbite versus accessing current shelter system as is. I think yeah, I would probably it's a great question. I think I would probably consider it in the same way as you would any other harm reduction conversation and have to open up the conversation, see where the individuals are at, and then consider strategies from that point of view. I think that would be yeah, it's outside my area of expertise. I mean, I'm coming at it from a an emerged nurse point of view where we put band-aids on people, and so I think I would actually look to your group from that. As well as that would be the primary prevention of stopping the frostbite in the first place. And then the secondary one would be if you get frostbite and it looks bad, and what does it look like and how does it feel? Trying to get those folks into emerge sooner would make an impact. I think there's a yeah, utilizing our acute care system to prevent frostbite or to rewarm is, from my opinion, an appropriate use of our emerge department. If there's not an additional, if there's not if there's not a alternative for that individual.
Great, thank you. And a shout out to all our emerge nurse colleagues who do a lot more than what you said. They're amazing. Okay, next question. Thanks so much for presenting this. I'm wondering if there's any indication as to how the city establishes their cold weather emergency temperature parameters. It's frustrating to see people struggling to get inside when it's not cold enough for emergency measures, but knowing that they're going to experience cold injuries when they're moved along. Do you have any
Yeah,
insight
no,
into that?
yeah, I think traditionally the -20 came from Environmental Canada, I believe. And I think those Environmental Canada thresholds for extreme weather response are meant for the general population that aren't vulnerable, that are walking their dog with appropriate winter clothing. And so I think that's where those come from. So if you're walking your dog at -20 plus there's a whole bunch of wind, yes, you got to be careful that you might get frostbite in 10 minutes or an hour. Those aren't designed for exposure over a long period of time. And so when you look at the workplace health and safety guidelines for outdoor working, they put in guidelines for like 5 degrees, 10 degrees, 0, minus, -5. And so they have a lot different guidelines that require mandatory rewarming at particular temperatures that have nothing to do with -20 for 3 days plus wind. So I think it was just that lack of awareness of using Environmental Canada cold weather response guidelines in relation to a vulnerable population that don't include if you sit down, hours worth of exposure versus minutes. I think that's where that comes from. I think there's a growing understanding of this. There is absolutely a growing understanding of the folks that are responsible for the policy that they're moving forward with expediting that to the decision makers, and so to be more evidence based.
That's great. Thank you. And thanks. I know you've done a tremendous amount of work on that. So thank you for all your advocacy. The next question is around emerge wait time. So do you have any idea how long it takes a patient to be assessed and receive iloprost once they actually show up in the emerge with frostbite? You talked a little bit about expediting, so wonder if you could highlight that again. Yeah, I often find patients with substance use disorders leave prematurely due to long wait times.
Yeah, no, that's an excellent question. I think it depends how bad of a disaster it currently is right now. And so we have our merged departments in the last number of years have moved from disaster level care to good levels of care, depending on the availability of a free bed and a free nurse to manage that patient. And so we we know of, and so the 10-minute, we have a goal, arbitrary goal of aspirational goal of 10 minutes of rewarming upon ED arrival. And that was made up specifically because if we don't have a goal, then we can't measure it. And so we have a goal for time to ECG because it's ischemia, and we have a goal time to rewarming. We went backwards and forwards actually with Calgary because there's moral distress with starting that goal, and they felt that as soon as possible is a reasonable language. But I guess that challenge is it's not on the individual nurse to provide a bucket of warm water for that patient or not, because they've got other things, other more say triage tasks to do. It's on the system. Um, I think if the patient is able to self-care, there's documented incidents of like, I'm sorry, please go warm up your hands in the sink, and that's as good as we can do. And then other times where we can get there's been delayed care, and so I think we understand what we should be doing, but and that when we put the requirement onto our nursing team, we also have to allow them, we also have to be aware of the risk of moral distress, because we say, hey, please try to meet this care standard. And if we don't, there's moral distress. Um, that adds to the ongoing moral distress of not being able to provide appropriate time care to any of the life-threatening injuries. I think it takes a system approach to be setting up and being organized to provide a bucket of warm water with analgesia support to a patient that comes present to our emerge department. It does take a system approach in the same way as we wouldn't triage somebody with a tourniquet to our waiting room. That's what we do when somebody has a frozen tissue, depending on how much frozen tissue. So it highlights the timeliness of therapy, does highlight the current practice variation that we have and challenges in our emerge. And it, and we see that in the data. We see cases that are waiting, that we know that are waiting, but at the same time, so are ischemic chest pain patients. And so I think it's aspirational goals that requires a free healthcare provider to support. If that kind of answers your question.
Yeah, that's great. And I love how you've talked about that in reference to other things that we're trained in emergency medicine, for example, and emergency care nursing. So I think helping people draw those parallels can be very helpful. And certainly that's a technique we've used a lot, as we've also tried to improve care and acute care for people who use substances as well. Do you have any other thoughts on why there's such a big difference between Edmonton and Calgary and what might be happening there beyond iloprost?
What I think it's potentially it's most likely. Well, I mean, there's the significant increase in the substance use. There's a different supply of. I don't know exactly the outdoor overdose rate in Calgary versus Edmonton. I know there's a different drug supply for both cities. Um, I mean, if you're unconscious outside and it's minus 30, it doesn't take long before you get an injury. And so that might be driving it. There's the unsheltered population that is significant. And so that's potentially, when we look at our primary drivers, it's unsheltered substance use. And it would be substance use in the context of substance use outside. And so I think that would be where most likely the drivers are. Interesting enough, I looked at a non-peer-reviewed work from Interior BC, Kelowna. They also report a very similar, a lot, basically a weekend numbers at the ALEC over 5 years, but the population was similar with unsheltered population. E2H or substance use again is a primary driver in a significant proportion of the patients. And that also lends itself to the 5 cases out of 6 in Whitehorse that had severe injuries with E2H intoxication. So I think if you're unconscious or altered outside and it's cold, that's a primary driver. I would suspect. I think the benefit is if we have a safe place to be consuming either at home or in a bar, and we have a shelter, then you don't have frostbite. I think is the classic. If you make sure you don't go to sleep in the snowbank if you're drunk coming back from the bar, but then it's like for this vulnerable population that might not be the option, and so yeah.
That's great. Thank you. Yeah, I realize it's complex for sure. And there are big differences between Edmonton and Calgary in a number of different ways. Do you have any last words or advice or things that you think for those of us that care about and work with and care for people who use drugs, anything you think we can do collectively to support your advocacy efforts on this topic?
I think if you don't work in a center that has a acute frostbite process, that's the band-aid side of things. So at least we can do is support this vulnerable population when they come into our emergency departments. When we started caring in Edmonton, we recognized that we had the highest case volume in the world, and I think if you work in a site, excuse me, if you work in a site that doesn't have that, I would advocate for that, and that would be a cost. But that would be work with the emergency department partners and general internal medicine. I think working in the community, I think frostbite is one ED presentation that you can look at that disproportionately affects this vulnerable population. I think it provides uh, a spotlight into this high risk group. I think whether if you can use frostbite as a spotlight into that group, and then because any of the primary prevention measures that you would put in place to prevent frostbite would also support that vulnerable population with most of their other health concerns as well. And so if need be, I think it does kind of support that piece.
That's great. Well, thank you very much. We really appreciate your time today and your expertise. And please pass on our thanks to Dr. MacLean as well. Wish him safe journey home. Just to remind everybody, this webinar will be recorded and be on the CRISMPrairies.ca website. Our next session is on March 18th, and we'll have a presentation on system dynamic modeling in opioid use. So really hope you can join us for that. Donald, a huge thank you again. Thank you so much. We're really grateful for your time and wish everybody a wonderful rest of your day. Thank you.
Thank you.